Welcome to Indonesian Pediatric Society webinar COVID-19 series. Today, the title is the new adaptation era and future COVID-19 vaccine for children. In this webinar, there will be 3 speakers. First, Professor Fiona Russell, Director of the Child and Adolescent Health PhD Program, Department of Pediatric, the University of Melbourne, and group leader for the Asia Pacific Health Research Murdoch Children Research Institute in Melbourne, from Melbourne, Australia. The second speaker is Dr. Anggraini Alam from Bandung, Indonesia. She is the chairwoman of the Infection and Tropical Disease Working Group of IPS. And the last speaker, Prof. Kim Mulholland from MCRI Melbourne and London School of Hygiene and Tropical Medicine, London, UK. Prof. Kim also group leader of New Vaccine Research Group. Before we start our program, our session, Professor Hartono Gunardi, the third chairman of IPS, will deliver a keynote. And at the end of the presentation, before discussion, two panelists, Professor Sujatmiko and Professor Zakiuddin Munasir, will share their comments and remarks. For your information, for the participant, the discussion session will be held after 3 speakers and 2 panelists. Before we start, may I inform you the rules for the webinar. Participants are welcome to ask questions that can be directly sent during the presentation of the material through the chat column in Q&A mode. Member of IPS does not need to write ID member. If participant experience problems in streaming sound or video, please press the reconnect button to improve streaming quality. And now, shall we start our session? I want to invite Professor Hartono to deliver his keynote remarks. Please, Professor Hartono.
Thank you, Prof. Sisi. Prof. Sisi is the Chief of Indonesian Pediatric Society Immunization Task Force and my senior colleagues. Thank you. Good afternoon, Madam Moderator, IPS President and Board, and also website committee, scientific committee, distinguished speaker from Melbourne Royal Children's Hospital, dear IPS member in Indonesia, and also maybe the audience from Australia. Greetings from Jakarta. We are lucky today that we have an opportunity to meet outstanding IPS and Australian immunization experts from Melbourne Royal Children's Hospital in our online symposium. We are all suffering from COVID-19 pandemic. Data from Worldometer reported that more than 200 countries are infected. More than 27 million people infected with total deaths of more than 901,000. Australia has more than 26,000 cases with 91 daily new cases with total deaths of 781 currently. Indonesia has worst experience. Total case in Indonesia has exceeded more than 200,000 cases with total deaths more than 8,000 cases per today. This pandemic created problem in economic, social welfare, health service delivery or assessing, including immunization and child health. This important issue will be addressed by Professor Fiona Russell, our distinguished speaker from Murdoch Children Research Institute, Melbourne. She's also enlightened us about the future COVID-19 vaccine candidate from Australia. WHO and UNICEF has warned us that there will be a decline in vaccination during COVID-19. Globally, the reduced immunization coverage of DTP3 is about 36%, IPV decreased 81%, and measles containing vaccine decreased 35%. This low coverage will potentially induce the outbreak of vaccine-preventable disease such as measles, diphtheria, and polio. Ministries of Health and Indonesian Pediatric Society have launched immunization recommendation during COVID-19 pandemic. But the immunization, including the catch-up immunization, should be carried out cautiously with special attention to the safety of children, parent or caregiver, and health workers. This important issue will be discussed by Dr. Anggraini Alam, the chairwoman of IPS Tropical Pediatric Infectious Disease Working Unit. In new adaptation era, people is encouraged to wear masks, do physical distancing, and frequent hand washing. But the compliance to the safety protocol is low due to several irrational reasons, such as risk-taking behavior or ignorance in adolescents and young adults, until the conspiracy theory. And also there is also a problem or scarcity of the mask. Some people said contact with COVID-19 will induce herd immunity, but it certainly will pose the risk of developing severe COVID-19 disease. The low compliance to apply preventive measures and the drive to do daily activities such as back to work in the office, opening mall, restaurant, and starting school attendance at boarding school make the number of COVID-19 in our country is increasing. Is there any preventive measure to reduce SARS-CoV-2 transmission? We can hope and rely on SARS-CoV-2 vaccine. There are at least 6 COVID-19 vaccine in the phase 1 and 1 candidate in phase 2 trial. This important issue will be addressed by Professor Kim Mulholland from Murdoch Children's Research Institute. He is also the founder of Global Action Plan for Pneumonia and leads pneumococcal microbiology and immunology laboratories at the same institute. We will have 2 other experts as panelists, Professor Zakiuddin Musnasir from IPS Allergy and Immunology Working Group, and Professor Sujat Miko, the Secretary of IPS Immunization Task Force. IPS extends sincere gratitude to our distinguished teachers, speakers, moderators, and organizing committee, and all the audience. We hope that the symposium will be of benefit for all of us. Thank you.
Thank you, Hartono, for your keynote remarks. And now we will start with our session. We welcome Professor Fiona Russell to start your presentation. Please, Prof. Russell.
Thank you very much, Professor Sisi, and I wish to thank very much the Indonesian Pediatric Association and Professor Kim for extending the invitation to me to talk to you today. It's a great honor. When Kim said there's about 2,000 or 2,500 people, I found quite daunting. It's the biggest talk that I've given, but also for Zoom, having 1,000 people on the line. And the lovely thing is actually I wasn't expecting to see people's faces, and it's really nice to be able to see some faces on the line. I thought I was going to be talking to a blank screen, and I actually saw somebody driving their car and listening as they were driving along the road. So that's lovely. So, but I'd first like to just start, as we do in Australia, our traditional welcome. So what we first do is to pay our respects to the traditional owners of our land in which I'm sitting on today. And for me, that's the Wurundjeri people of the Kulin Nation, and to pay my respects to their elders past, present and future. And as sort of mentioned, I'll be talking about the global situation for children in the era of COVID. And I'm going to touch on vaccines, but really I'm going to leave most of that to Kim to cover after me. Okay, so I think we're probably very aware of these statistics, and I won't dwell on them too much, but just to say that, you know, the Philippines and Indonesia in our region are very high in terms of numbers of cases and deaths. And also here, this is the global picture, really with the three countries, we have the most cases at the top, India, United States and Brazil, and this is a logarithmic scale. We have Indonesia and the Philippines sort of very close here, and then other countries down below. And then in terms of also the deaths, again, I'm sure you're very familiar with this, that, you know, locally in Indonesia, issues with mortality statistics. And so when we look at the age distribution of infection, so this is looking at infection in people who are positive for a test. And I've just put up two countries here, Australia and South Korea. So when we look at Australia's data, you know, the proportion that are positive in children or people under 19 years of age, it's sort of much lower than the other age groups. And this is really consistent around the world, where there's a lot of testing being done. And you can see a very similar pattern in the number of cases there in South Korea. And obviously the deaths are much lower by and large in children, and close to zero in many countries compared to adults. So in terms of the direct effects of COVID, and you know, yourselves in Indonesia know a lot more, you know, about this than me, and I'm sure you're, you know, very up to date with this. But as you are aware, you know, it's mostly has no symptoms in children as a mild disease. Hospitalization rates in children are very low compared to adults. But there is a syndrome called multi-system inflammatory syndrome in children, which does occur, but it is uncommon. And I saw this, it came out in the Asia Pacific Pediatric Society newsletter about Indonesia, you know, having the world's highest rate of child deaths from COVID. There was about 300 or so. And, you know, I'm sure there's been a lot of discussion. We might hear that later, or you probably discussed that last week even. But really, there's very few published studies from low and middle income countries. A lot of the information on the epidemiology is really coming so far from higher income countries. Now, when we look at the perinatal outcomes of COVID, recently this week, the University of Birmingham are doing a living systematic review of perinatal outcomes, and they released this paper in the BMJ this week, and where they reviewed 77 studies, and they found that 10% of pregnant women or recently pregnant women attending or admitted to hospital for any reason were diagnosed as having suspected or actually had COVID. The pregnant women with COVID compared to the pregnant women without COVID were more likely to be admitted to intensive care and more likely to need mechanical ventilation. There was 0.1% mortality of pregnant women with COVID. And for newborns, the odds of a preterm birth were 3 times higher, which is very concerning, because there certainly was reports earlier on that that the preterm birth rate may well have gone down. And also the odds of admission to neonatal unit is 3 times higher than babies born without COVID. Now, they then looked at the risk factors for severe COVID in pregnant and recently pregnant women, and they found that being of higher maternal age, being obese, having chronic hypertension or pre-existing diabetes were all risk factors for a poor or for severe COVID. But most of these studies are from China, the US, the UK, Netherlands, Spain, and Latin American countries. So very few, again, from low and middle income countries. Now, I want to sort of diverge a little bit about here and talk about epidemiology in general, because, and it's really important to understand epidemiology of COVID in the local context, because it seems to be emerging that it is quite different. So in Africa, the number of cases and deaths remain low, except in South Africa. South Africa has a problem. But in all the other sub-Saharan countries, African countries, it's really seems to be that cases and deaths are low. And we don't know why. Is it because of the younger age of the population, so not many old people, and so not many comorbidities in the population? Is it because of pre-existing coronavirus antibodies to other coronaviruses that are cross-reactive to the SARS-CoV-2? Is it because of school closures and lockdowns and interventions that have intervened and prevented this, or other environmental conditions, or is it in fact underreporting? So it's essentially not known, and there's a paucity of good quality data to be able to explain this in African populations. However, there is a preprint that's just been released in the last few days from Kenya, which is very interesting. And by August, they had done in Kenya over 23,000, they found over 23,000 positive swabs out of over 300,000 tests that they'd done. And they had almost 400 deaths with a positive test. And what they found, and what this means, when they looked at what was happening in Europe, the number of deaths was extremely low when compared with the 200 or 250,000 cases and the 30,000 to 40,000 deaths for similar sized countries in Europe, so France, Italy, and the UK, at equivalent times into their epidemics. The seroprevalence, however, was very similar. So in May, June in Kenya, when they did a representative sample, they looked at antibodies and found about 5% of the population had antibodies, so had been exposed to the virus. It was a bit higher in urban centres. And this prevalence was similar to the UK in May, in Spain in April and May, and in March, April in some US cities. And these places had much higher deaths. So it really was quite unexplainable. So they looked at a mathematical model, and they used their 3 sources of nationwide longitudinal data, which does suggest the number of COVID cases and the mortality risks are substantially lower in Kenya than in Europe and the USA. And it actually predicted or suggested that the peak has already happened in Kenya, and that happened in July, and that about 34 to 40% of the urban population had already been exposed. And it had peaked during a time when there were relatively few restrictions and physical distancing. And so although there's been a lot of talk, certainly in high income countries, that herd immunity is just not feasible, it may be different in other settings. And so it may be in Kenya that this epidemic may well be resolving through population and immunity. And that's been a suggestion also in India as well, where seroprevalence was very high in some settings and it seems to be dying out. However, there is a big problem, and we really need to understand the epidemiology, and we have to understand it very well because of the impact that it's having on everybody, and no less the children. And really, as we know, the impact on children will be mostly the indirect effects rather than the direct effects. And the reason for that is because of increasing poverty, because of people losing their jobs, the lockdown, not being able to work, etc. There's also reductions in access to essential care. So this is some data, modelling work actually that was done to estimate what would happen with reductions in essential services. And it was estimated to result in an increase of between 10 and 45% of under 5 deaths per month. There would be an increase in wasting, would account for between 18 and 23% of additional child deaths. And then access to treatments such as antibiotics for pneumonia and neonatal sepsis and oral rehydration solution for diarrhea would account for about 40% of the additional child deaths. And in total, it's been estimated about 1.2 million child deaths in the next 6 months due to these disruption in essential services based on the worst case scenario. Additionally, malnutrition, of course, is such a massive, or potentially a massive issue, and there could be up to 370 million children who may miss out on nutrition that's administered through school. So many children, many countries have programs where vulnerable kids are provided with nutritious meals at school. And so as we know, that will impact on measles and other infections such as pneumonia and things if there's more malnutrition, and also the disruption of the immunisation services that we've already just heard about, maybe resulting in about 80 million children under the age of 1 missing out on their vaccinations. And so I'm sure we'll hear about this a bit more later, and I'm sure the audience is very well aware of the WHO guidance in terms of how to adapt essential services for child and immunisation, and how essential they are to continue throughout this pandemic. WHO did a pulse survey recently globally to look at what proportion of countries have had disruptions to essential services, and this was released in the last 10 days. And they found that very worryingly, you know, for children, immunisation services, this is in 105 countries that responded to the survey, you know, about half or so had disruptions to immunisation services, and that's fixed, you know, facility given. The outreach services, about half as well, and then sick child services, you know, 50% reported disruption of services, and also about half with management of malnutrition. So these are all extremely worrying statistics. Additionally, there's the impact of children of lockdown and closing of schools on children's mental health. In Australia, there was a national poll done by our hospital, and 1 in 3 parents said that COVID had negatively affected their children's mental health. And this is often, you know, something that's really not well monitored. Actually, we hear a lot about it, a lot of anecdotal reports and things, but not well addressed often. So now I want to really turn a lot of attention to schools, because really this has been such a major disruption for families across the entire globe. And so I want to focus now on school closures. And so this is a map here that looks at school closures across the world. It's not quite up to date because where I'm sitting down here at the bottom of Australia, almost the bottom in Melbourne, our schools have been closed for at least 6 weeks. And so that should be, well, actually, no, they've opened up in other states. It's just Victoria where it's closed. And so the red is sort of where they're closed. Oh, sorry. So the yellow is where it's recommended. Green is no measures. The orange is sort of required, but only at some levels. And the red is required at all levels. So there's been massive disruptions globally with school closures. And this is the amount of children that have been affected by this. I mean, it's just a massive amount of children who are not going to school at one stage or another. And then when we look at our region, again, it's 100 million children, you know, who have been not going to school. I mean, it's a massive amount of children who are missing out on their education and potentially all the other social services that get given through schools. And so what I want to focus on now really for the rest of the talk is really the role of children in schools and the importance of schools, and trying to figure out what is the role of children in transmission. So very early on in the pandemic, we thought that that transmission from children was relatively low. And we know, you know, as that picture, that horrible, quite horrible photo shows, is that children, you know, are really responsible for almost every other virus, you know, influenza, RSV, and certainly bacteria, pneumococcus. You know, they're high carriers of these, you know, virus or bacteria. They're less likely to wash their hands. They, you know, run around each other at school and preschool and kindergartens, and they spread it all over everybody. So, you know, this was very surprising early on. We thought, well, that's very unusual. Is it really the case? But more recently, there's more information that's coming, and it seems that older children transmit the virus at a similar rate to adults, and that some factors may actually increase the transmission from children. And that a large portion of infected children may be, you know, not having any symptoms at all, or pre-symptomatic, and asymptomatic and symptomatic individuals shed virus, you know, for 2 to 3 weeks even, regardless of any symptoms at all. And so children under 5 with mild to moderate COVID studies have shown that they have high viral load in their nasopharynx. However, having a positive PCR doesn't mean that they're infectious. It just means they've got some viral fragments. And so it's not known whether having a positive PCR is still whether the child's actually infectious or not. But it has been shown, oops, I'll just change my screen, that there is a correlation between higher so DNA level or RNA levels, so higher load and the ability to culture infectious virus, suggesting that young children can potentially be important drivers of the virus. And so there was a recent study from South Korea that was, actually, I think it's a preprint as well. I'm not sure if it's published yet, but it was in 22 health centers, and they tested 91 children every 3 days, and they followed them up for a number of weeks. And so 20 of them had no symptoms, 18 were pre-symptomatic, and about half of them had mild to moderate symptoms. And most symptomatic children had symptoms for a median or average of 3 days, but you can see there it was up to 28 days prior to being diagnosed. The pre-symptomatic children, so these are the children that didn't have any symptoms but then went on to have symptoms later. They didn't have symptoms for about 2.5 days, but up to 25 days they didn't have symptoms, despite having a PCR positive test. So it means that there's a lot of children going around that don't have any symptoms, that are testing positive, and that can be up to 25 days. And then only 7% were identified with the test performed at the onset of symptoms. So if you only test children at the time that they're getting symptoms, then you're missing the vast majority. In other words, 93% go unnoticed. You know, they either don't have symptoms or they have very mild symptoms or go on to have symptoms later, but they're still positive and they may be transmitting the virus. So as I've mentioned, surveillance that just tests symptoms in the children who have symptoms will fail to identify children who are shedding the virus with no symptoms at all. And if face masks aren't used, then these asymptomatic carriers may be a reservoir for silent spread. And half of symptomatic children in this study were still positive at 21 days, which is 3 weeks. It's a long time. So as I've mentioned before, we don't know whether this means that just being PCR positive doesn't mean it's still infectious, because you have to be able to grow the virus to show that it's still infectious. And sort of very worryingly, that 98% of children had either no symptoms or mild or moderate disease. Now, with this data, you would think, well, gosh, there must be outbreaks in schools everywhere. If that's the case, you know, if children have got all of this and are sort of, you know, and they're just going around, what's happening in the schools? So England did a study, and they've just published this, well, actually, I don't think it's published yet either. It's in their preprint, but where they looked at 2,100 school staff and children, they tested them for antibodies. And so they found that 10% of the students were positive and about the same number of staff were positive. And what that suggests is that children are just as likely as adults to be infected. So they're positive, doesn't mean they get sick, but they get exposed and they get infected with the virus at a similar rate as adults. Now in England, fortunately, only less than 0.1% of open educational settings had an outbreak. So when they looked at their data in June. And out of more than 1 million children attending preschool and primary school in June, only 70 were infected, so tested positive by PCR. So very few positive cases in children were detected, despite 10% of children showing evidence of exposure to the virus. So again, you know, just relying on PCR testing really underestimates the amount of penetration of the virus in the community. And also it's likely, you know, that children experience these mild symptoms or no symptoms at all. So further supportive evidence of that. So what they also said that children and staff who attended school more frequently were no more likely to test positive for antibodies than those who did not attend school or went less often. So what this means is that infections in the wider community were likely driving the cases in the school children. because, there were, it's likely that the children were getting it from the community rather than from the school itself. And so, in summary, what they had said was that it suggests that attending preschool and primary school brings no additional risk to either staff or students. However, this study was done during low periods of transmission in England, and it also was only, it wasn't done in secondary school, so it's in the lower level. Now, looking at the European Union, they did a survey a couple of months ago, and they found that there were reports of clusters of school outbreaks that occurred in several of the 15 European countries that responded to the survey, but they were very limited in size and number, and they thought that they reported that they were just exceptional events, so very uncommon. Several countries said that the school setting they thought didn't play a significant role in the transmission of the virus. Secondary transmission in school they thought was either or from either child to child or teacher to child or child to adult was perceived to be very rare. And the responses suggest that so far the schools have not been a major outbreak environment in the EU and the UK. And that's been the same for Ireland, France, South Korea and Singapore. I mean, there are cases, of course, but they're low in number. But I have to remember that there's a mitigation strategies as well. There's social distancing. Some countries have masks. There's all the hand washing. There's all those other things to make schools healthy as well. And so in Sweden, you probably paid some attention to, because Sweden had a very different approach to the response to, and sort of by and large stayed open, and schools were stayed open through the entire epidemic. Unlike Finland, where schools were closed. So in Sweden, schools were open except for children 16 years of age. And so Sweden did a comparison between themselves and Finland. And what they found is that the infection rates in daycare centres and school children were no different, really, between the two countries. And primary school closure and reopening in Finland didn't really have any impact on the weekly number of cases in primary school aged children. But bearing in mind, there were those social mitigation strategies to make schools safe for children. It wasn't just go back as normal. And there was also, importantly, for the teachers, there was no increased risk of infection in Swedish teachers and childcare workers compared to other professions in Sweden. But outbreaks do occur in schools. And so it's really important to understand what are the situations, I guess, that come together to make that happen. So in Israel, they had closed school and then they reopened schools. And within a couple of weeks of reopening schools, they had a big outbreak in a secondary school. And what happened there when they did some analysis, there was a big heat wave. Temperatures were over 40 degrees. They had been wearing masks, but because it was so hot, they told the students you don't have to wear masks anymore for a few days. And they also used air conditioning in all the rooms. And they have very large classroom size of up to 40 children in a classroom. After school, there's lots of contact, lots of social activities, and lots of children travel by bus together. And so that was really all those circumstances that sort of converged for that outbreak to sort of happen. Now, in the US, often they have summer camps where children go and attend summer camps. And so they're all sleeping together, singing together, playing and doing sports together. And there was an outbreak there was over 500 children in that camp and very high attack rates. So children aged 6 to 10, about half of them got infected. In 11 to 17-year-olds, 44%, and in 18 to 21%, 33%. So, this really shows that children are susceptible to infection and efficiently spread the virus, but in certain circumstances. So it's in certain circumstances where there's a lot of crowding, poor ventilation, all these sorts of things where social mitigation strategies aren't possible where it's occurred. So it's really important then with reopening schools to open up in a safe manner to prevent any outbreaks and school closures, because it's so important for families to get kids back to school. And so I'm not going to go through the details of this, but Harvard has put together a healthy buildings program to help guide people on some strategies that could be helpful. And really importantly is ventilation. So as much as possible, teaching outside and doing everything outside, and similarly with health services for immunisation visits and primary health care, as much as possible doing it outside in fresh air is really important, and avoiding crowding and wearing masks, and these are very simple things that everybody can do. So, in finishing off, it's really, now I'm sort of just going to touch on COVID. Are COVID vaccines warranted for children? So it's really important to understand the context and the epidemiology and the local context. So we really need vaccines that not only prevent severe COVID, but also transmission, because, to get life back to normal and to turn the switch off, to stop all that community transmission, we have to be able to potentially vaccinate everyone. And it's really important to understand what children's role in transmission is. So who to vaccinate? Children, well, we really have to understand their role. We know that outbreaks in schools occur. We know they get infected. We know that many countries have crowded classrooms, or the kids travel by school buses. And we also know that many countries have trouble with water and sanitation, and access to hand washing facilities with soap and water are really very challenging for many countries around the world. And for pregnant women, well, should they be vaccinated too? Well, provided, of course, the clinical trials need to be done, but the perinatal outcomes do appear to be worse. And again, most of the data is from high-income countries, but we know in low and middle-income countries where there's access to universal health care, where oxygen and intensive care are highly variable, it's really likely that in low and middle-income countries that perinatal outcomes may well be worse. As well in these settings, because the treatment services aren't available or as accessible. So in summary, it is so important to maintain essential child and immunisation health services. Children may be just as likely as adults to be infected, although of course, not getting as much severe disease, but we have to really understand the role of transmission. It's really important. It's really important, not only for vaccination, but the school situation. And also extremely vital to have local descriptive epidemiology. Boring old basic epidemiology is never, never very exciting, but it's more exciting that, it really is absolutely fundamental. And it's so important not to be relying on the data from high income countries, because every setting is quite unique. How people mingle, how class sizes, there's a whole range of things that make things very unique to each individual setting. So these are some of the basic things that I think, in terms of studies, which countries should sort of work towards, and to try and understand their epidemiology. So looking at risk factors and outcomes, by age, sex and profession, particularly essential workers, because, these are the people that can't work from home. So these are the people that potentially will be keeping spreading it and transmission going. So really understanding, apart from obviously, healthcare workers, who else is at high risk? Comorbidities, ethnicity might be, depending on the setting, socioeconomic status, access to care, and other locally relevant factors, of course. Pregnancy cohort studies, again, extremely important to be done in different contexts. WHO has a standard protocol, so if that's something of interest, there's a protocol and all the SOPs in a database even for that. School studies important, to really understand about school closures, when to shut them down, when to reopen, understanding that is just really important. And seroprevalence surveys, as I've alluded to, having PCR testing is one thing, but it vastly underestimates the real penetration of the virus paper. That is just really fascinating, and it's important and sheds a whole new light in terms of understanding what's going on in different contexts. And so, and why it's so important, the epidemiology, is because it then informs those mitigation strategies, as I've said, and vaccination prioritisation. And again, the final point is just really about how important it is to open up schools safely, but the most important thing really is what's happening in the community. If you've got low transmission in the community, then schools are very low risk for children. But if you've got lots of transmission going on the community, then that spills over into the schools. So it's not the schools per se, but it's just what's happening in the community that obviously affects the schools, and important to sort of help with the education department in helping schools get their schools safe for children and their learning. So thank you, Terima kasih to everybody and the organisers, and just like to say it's very hard to keep up with everything, and so we put out this weekly for research evidence update, and it's free, it comes out every week, and you're more than welcome to check out all the recent evidence that we summarise every week. Thank you very much.
Thank you, Prof. Russell. For your fruitful presentation. We all will benefit from your contribution. So thank you very much. So the second speaker is Dr. Anggraini Alam from Bandung. She is the chairwoman of the infectious and tropical disease in the group in the IPS. Please, Dr. Anggraini,
thank you.
You can start your presentation.
Thank you, Prof. I hope my voice and also my PowerPoint look clearly.
Yeah, it's clear.
Thank you, Prof. Yes. So, Prof, thank you very much for this opportunity. Good afternoon. Assalamualaikum warahmatullahi wabarakatuh to our professor, doctors, and colleagues. Especially the board member of IPS. This is my presentation about child-friendly infection control services during pandemic. So we have to know our children vulnerable to infectious diseases. This slide shows us that the cause of death of children less than 5 years old, many of them are caused by infection or infectious disease. So naturally, Prof. Russell have already said that children are vulnerable to infection. So we have to do a child-friendly health service that can accessible, affordable, and should be guided specifically needs and rights of children. But in COVID-19 pandemic, we have concern of morbidity and mortality in children. Therefore, we need many evidence-based child-friendly healthcare approach, because this pandemic is a new knowledge globally. So is infection control practices in children during pandemic differences from adults. When school closure and lockdown have been implemented in Indonesia and global or internationally, children were infected by family members. In Italy, showed that the unknown source of infection happened more than 50%, and they don't know the source, and maybe higher in Indonesia. In my hospital, about 80%, we don't know the source of infection of our children patients. So children have a natural curiosity and breathe more times per minute. So higher inhaled droplets contain SARS-CoV-2 and low heights. So droplets that heavier than air will accumulate close to the ground and in the breathing zone of children. And the most important, children are dependent on others for their care. So if the adult bring them outside house to the crowded area, they're very easy infected by others. Prof. Russell have already mentioned about this, how children may be a potential source of contagion driven the transmission of SARS-CoV-2 in spite of milder or asymptomatic sign and symptom. So lack of symptoms, children, it did not mean that they can't infect the others. This slide shows us the mutation of SARS-CoV-2 right now. The mutation affect from D614 to G or glycine that affect 3 amino acids chain. And we know that the viral load from G mutation were until 9 times larger than D. And then the G variant infected up to 8 times more cells than D. So that's why the D mutation was linked to higher viral load in the upper respiratory tract than the original one from Wuhan. So because SARS-CoV-2 mutation increased the ability to replicate and infect more cells of upper airways, it becomes easier the virus to transmit. It has already reported in Vietnam, Malaysia, and also Indonesia, the viral ability to transmit 5 to 10 times than the previous one. So that's why maybe the R0 will increase above 4.5. It could be. And this, we have already know the capabilities of persistent coronavirus interfaces, plus the concerns of aerosol transmission in the particular situation like many people in enclosed area with air conditioning for an extended period. So it will maybe double, triple, or maybe quadruple increase of frequency of SARS-CoV-2. And this is another characteristic of COVID-19 in children. The virus may persist on stool, so we have to be careful, waste their diapers. COVID-19 has emphasized infection control practices. The IPC team in hospital are important personnel. This team should feel valued, empowered through training, education, and they will build a system to prevent transmission COVID-19 in your hospital. And the doctors, nurse, and epidemiologists in IPC team will work harder right now. This slide shows us how to set up and equip triage. Ensure the patient have online appointment previously, check temperature at the entrance, check availability of face mask, install physical barriers to limit close contact with plastic, something like that, and ensure availability of hand hygiene station. And ideally, we separate hospital, COVID and non-COVID ones. Of course, it's not easy. And we want to screen with swab all children and caregiver when they're admitted to the hospital. Good ventilation being the key to prevent the spread of COVID-19. So it's simply by open the window. Appropriate PPE for healthcare worker, including pediatrician, and cleaning all surfaces. This is the mask, example of face mask and face shield in children. And we know WHO recommends 3 layers mask and face shield. This is in COVID-19. It would be ineffective to rely on symptoms. So as pediatrician, we have high risk infected by COVID children. So many paper reports on how telemedicine or virtual healthcare is being embraced like never before. It's inexpensive. Of course, it never be the same as physical examination straight to the patient. Telemedicine has the potential to help by permitting mildly ill patients to get the supportive care and minimizing their exposure to other acutely ill patients. By how you can see how we can take history illness, history of travel and contact, and self-physical exam by parents or caregiver. Take temperature and so on. This is pathogenesis of COVID-19 in adults when they have we call silent hypoxia or happy hypoxia. We did not know if silent or happy hypoxia happen in children as in adults, but the lesson learned, maybe we should check pulse oximetry minimum twice daily in COVID pediatric, although they are in self-isolation. And in the case of MIS-C or PIMS, the clinical children will be like this. Maybe the RDT or rapid test more reliable than RT-PCR because one of possible mechanisms that causes MIS-C could be via antibody-dependent enhancement or ADE, such in the dengue viral infection. This possibility will raise the concern if we enroll children in given vaccination trial. So maybe Prof. Muhalan will discuss about COVID vaccination in children and the possibility of ADE problem. Simplifying pediatric services is important in pandemic situation. Assess the completed medical history and vaccination records provided by the patient. And we have to prepare enough parking maybe. Should be available for a patient to wait around 15 to 13 minutes after vaccination. So maybe curbside of drive-through vaccination make the simpler for pediatric services. So again, COVID-19 has emphasized infection control practices, and these important personnel. So this team should be valued and empowered by the hospital management. We know that the healthcare workers, many of them are infected and die. First, in Wuhan, 1/3 of healthcare workers infected by COVID-19, and unfortunately in Indonesia, so sad, we have more than 100 doctors died from COVID-19. These slides show, 2 slides, how several ongoing studies to prevent us as pediatricians, as healthcare workers from SARS-CoV-2 infections, besides, of course, giving vaccination. One of them enrolled the BCG trial, enrolled in Australian healthcare worker. And this is study how to give post-exposure prophylaxis to healthcare worker. Okay, this is our sad history. When Spain flu pandemic happened in Indonesia, 3% of Indonesian population died, or around 2.5 million. So we have to follow all guidance, not just us as healthcare worker, but of course the community. That's the important thing, to protect us from COVID-19. This is Australia data. So Indonesia Pediatric Society recommendation about stay at home to all children during pandemic situation. Because Indonesia still have increasing number of cases, and we have to delay the school entry. And if they seek medical service, we have to prepare control action in our hospital or our clinic. Thank you. Thank you, Dr. Proxy. I hope my presentation was quite clear. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Warahmatullahi wabarakatuh. Thank you, Dr. Anggi, for the nice presentation. And then the last speaker is Professor Kim Mulholland. May I invite Prof. Kim to start your talk, please?
Better make sure I'm unmuted. Can you hear me now?
Yeah. It's very clear, and also your presentation. Yeah, your slide is.
Do you see my slides now?
Yeah, it's good.
Okay, thank you. Well, good afternoon, everybody. My name's Kim Mulholland. I'm a pediatrician, but most of my career has been spent working on vaccines and vaccine-related diseases. So I guess it's okay for me to talk about COVID vaccines. There are basically 4 types of vaccines. As you'll see in a minute, there are more than 200 vaccines under development, but most of them fit into 4 broad groups. One of those is the inactivated virus, which essentially expresses all of the surface proteins of the virus. The second is the dominant surface protein called the spike protein, or the S protein. And when you look at the cartoons of the virus, the spike protein is the thing which is sticking out of the virus on the, certainly that's what's seen on electron microscopy. The third is the nucleic acid vaccines, either RNA vaccine or DNA vaccine. And these are programmed to get the body to make the S protein. And then there are adenovirus vectored vaccines. either human or chimp adenovirus, in which there is genetic manipulation made to get the recipient of the vaccine again to make the COVID protein, the spike protein. Now, in all cases, you can measure the antibody in two ways. You can measure it directly by ELISA. And I think all of you are aware that ELISA antibody is antibody which binds to the antigen on a plate. So in the laboratory, if you stick the antigen in question, and in this case, mostly either the spike protein or some component of the spike protein onto a plate, then antibody will bind to that. And we call that binding antibody or ELISA antibody. And it's not necessarily functional antibody, but in fact, it probably mostly is. The second assay that people do is a functional assay. And the best functional assay actually is a neutralization assay, where a live preparation of virus is then neutralized by serum from the individual person. So that's perhaps the gold standard way of measuring antibody, but of course it's very difficult and can only be done in certain places. So the vaccines basically come in 4 types, but there are so many vaccines. I've written here 202, but there are actually more than that under development in many different places. Quite a number of them have reached human trials, and I've listed most of them here. And you can see that they do fit into those broad categories that I was talking about: the inactivated virus, the RNA or DNA, the protein vaccine, and the adeno express protein. So I'm going to speak a little bit about some of these, but not in detail. First, I want to talk about what's happened in the COVID-19 vaccine field. And some of these important issues of current concern today, actually. The first is that the pace of development has been greatly increased. Now, the last speaker spoke about the dengue vaccine. You may remember that the dengue vaccine has been quite a controversial vaccine after it was finally developed and evaluated. That is, particularly the first dengue vaccine, Dengvaxia. And yet that was a 10-year development program from when that vaccine was first developed in the lab until it was rolled out. So it was a 10-year program, and it involved phase 1, 2, and 3 trials. Now, the pace of development has been speeded up by 2 things. The first is squashing the phase 1, 2, and 3 together to produce a more rapid process. And then secondly, external support has been given to the vaccine manufacturers to enable them to build the production facilities while the trials are going on, so that there's not the usual long delay while the company decides whether they will build a manufacturing facility or not. So these things have speeded up pace of development. Next question is safety. Now, the last speaker mentioned enhanced disease. Antibody-mediated enhancement was the term that was used to describe the more severe disease that was seen in those dengue vaccine recipients who had been seronegative at the time when they were vaccinated. So children who were vaccinated before they had been exposed to dengue, then when they encountered the virus, the wild virus at a later stage, tended to have worse disease. Now, this type of thing was first seen with the respiratory syncytial virus RSV vaccine more than 50 years ago. And it's always been a problem for RSV vaccine development, and it's been seen with some other vaccines as well. So it is a risk. It's not just a theoretical risk. And one of the early SARS vaccines that was developed 18 years ago against the SARS coronavirus did actually produce enhanced disease in animals. The vaccine was never trialed in humans. So this is a possibility that we have to consider. The third issue to think about is the vaccine access. Who gets the vaccine, which countries get the vaccine, and which people get the vaccine? And vaccine nationalism is a term that's been raised by the Director General of the World Health Organization, Dr. Tedros, as he's been trying to figure out a way for vaccine access to be fair and equitable in a world which is far from being fair and equitable. But he's done his best, and I'll describe some of what he's done to do that. And then finally, the question which has been already raised by previous speakers, who should be vaccinated? And there is a lot of work going on at the moment about trying to prioritize vaccines within countries, or prioritize vaccine administration within countries. WHO have a working group on this issue, and they will be producing a working document in the coming weeks. But in general, though, the prioritization is a national decision. So countries will be making their own decisions, but pretty well all countries would start with healthcare workers, both because they're at high risk, because they really deserve to be vaccinated, and also because loss of healthcare workers, as has already been alluded to in Indonesia, but also in all countries actually, is a major problem for a country that's facing the pandemic. The elderly are definitely at highest risk, and especially elderly with comorbidities, especially with hypertension. And most countries will have the elderly following as the highest priority. And then after that, it's unclear. I've put pregnant women with a question mark there. Fiona mentioned pregnancy and the increased risks associated with pregnancy. It is of note that most companies have not included pregnant women in their trials. So the safety of the vaccines in pregnancy will remain a problem. But I think they should certainly be considered. And I've listed there the other groups that have been discussed, and different countries have different priorities. Some countries, incidentally, will be vaccinating the military first. Now, before going on a little bit more into this business about the vaccines, I want to say a couple of words about something called CEPI. We keep hearing about CEPI in the news and indeed in many meetings. It's the Coalition for Epidemic Preparedness and Innovations, which is not a very easy title to understand. But basically it was formed in 2017 to try and establish a system to develop vaccines to stop future epidemics and pandemics. It was started by the Norwegians, and it is a Norwegian association with 12 voting members who represent industry, various aspects of health and science, finance, and other aspects. So the main thing about CEPI, though, is that they have got quite a lot of money, and they have been helping companies in their process of development of vaccine. Now, CEPI has worked with Gavi, the Global Alliance for Vaccines and Immunization, or what is now called the Gavi Alliance, which everybody I think is aware of, and WHO to launch this thing called COVAX, which is a system to try to provide vaccines to the world. It's not clear how successful that will be, but COVAX basically involves those three organizations, and I've summarized their roles in this slide. CEPI is responsible for liaison with industry, and they have been working with companies, particularly to help them speed up the manufacturing process and the regulatory process. WHO have been responsible for strategic issues, policy, access and allocation issues, and they have already actually just completed, or I've seen a draft of the global ethical guidelines for the use of COVID vaccines. Gavi is responsible for procurement, and this comes into something called the COVAX facility, which is a kind of advanced market commitment, really. And then for other issues around country readiness and the delivery of the vaccine. And the delivery of the vaccine is not trivial. I don't know many countries that have successful vaccination programs directed at adults. And that's going to be a real problem for just about every country in the world. The COVAX facility, though, is essentially a financial pooling system, and it's about sharing the vaccine development risk. And they've also, as I mentioned, invested upfront in manufacturing, and they are really about partnerships with vaccine manufacturers. And then this this is from their website, this very strong statement, COVAX unlocks the power of multinational corporations to move towards one collective goal. Well, this is very wonderful, but is this really going to happen? And I'm not really sure about that, because this is more likely what has happened. And these are all of the countries and groups of countries who have entered into bilateral deals, really advanced market commitments of different kinds with different manufacturers. And you can see there's a lot of countries there, and Europe is represented as one country. Many of them have got into deals with AstraZeneca. AstraZeneca seems to have been the most active of the companies in terms of making these kind of deals. A number of them are deals that involve a local manufacturer producing the vaccine under license. And India is a good example of this. The Serum Institute of India, which is the largest vaccine manufacturer in the world, has a deal with AstraZeneca, Oxford, and with Novavax, and as well as the other, Johnson & Johnson, sorry, have a deal with Biological E, which is another very big manufacturer in India. So these sort of things are going on, but the others are individual arrangements between countries and manufacturers. And of course, Indonesia has been working with Sinovac and has the arrangement, as I understand it, is for Biopharma Indonesia to be able to produce that vaccine under license should it prove safe and effective. So this is really the sort of real world. At the bottom here, we see the 9 countries that have part of the COVAX initiative, or the COVAX facility, they call it. And there are a couple of the major players there, but the others are less so. So there is a mixture of an attempt to try and get a fair, global, equitable arrangement, along with a whole range of different bilateral arrangements being done with countries. And in this slide, just for your interest, I've just summarized all of the deals that I'm aware of that involve the United States. And you can see they have cut these deals with 6 different manufacturers for over 1 billion doses, at least, which is far more than the population of the United States, and for a very large amount of money. And these are sort of pledges, as it were, with some money has changed hands. We don't know how much, but this is basically the United States government trying to make sure that they are the first ones to get an effective vaccine. This is the timeline of the leading vaccines, and the phase 3 trials are shown in blue here. I'm going to speak more about that in a minute. But the important thing to look at here is this black areas here, which represents the emergency use authorization timeline for the United States. And that basically means this is when these companies believe that they may be able to apply for the vaccine to be used in the US. And you can see that 3 of them, it covers October, which is of interest, but probably very unlikely. So I want to speak now about the very basics of evaluation of vaccines. The very first phase, for those who are very experienced in this area, I apologize because this will be probably second nature to you. But for many of the audience, I think this may be of interest. The phase 1 trial is a trial normally of around 100 or not much more than 100 volunteers. And the purpose of the trial is first to demonstrate that the vaccine is safe, then sometimes to look at different doses, and then to make sure that the vaccine produces the antibodies that we believe will be protective. And here are the results of one of these phase 1 trials. Excuse me. This was a phase 1 trial of the Novavax vaccine, which is a S protein vaccine, a subunit vaccine. And the first thing to look at is on the right here. These are levels of neutralizing antibody, titers of neutralizing antibody. The placebo group here got no neutralizing antibody, as you can see. The sera from humans who've had the disease, so convalescent sera, are shown here. Now, we believe on the right-hand side that these levels of antibody which are people who've recovered from the disease, that these are probably protective levels of antibody. So this is the area that the vaccine would be heading for, that's shown in blue. And you can see in the first group here, the 25 microgram with no adjuvant, there was a modest increase after the second dose only. So I hope you can see my arrow. This is the beginning, and this is after the first dose, and this is after the second dose. So not a very good look for the vaccine at that point. However, in these two groups in which the vaccine was given with an adjuvant, that is an adjuvant that's designed to increase the response to the antigen in the vaccine, you can see a stronger response from the first dose and a much stronger response to the second dose, both with the 5 microgram and the 25 microgram dose. Now, what that really means then is that 5 micrograms is enough and that the vaccine needs the adjuvant. So this is the information that you get from a phase 1 trial. And it's very important to go to the next stage, which is phase 2 or phase 3. The phase 2 trials are looking at safety and immunogenicity, and the phase 3 trial is looking at efficacy. And efficacy is usually against infection, but it can be against disease, and that's what I want to demonstrate. Now, this is a warning. This slide contains fake data. The first time I've ever presented fake data, but it means I made it up, basically. So this is a hypothetical vaccine trial. 20,000 subjects, half of them receive the vaccine, half of them receive controls. Now, amongst those 20,000 individuals, I'm suggesting that there are 600 cases of COVID infection identified, 500 in the controls and 100 in the vaccinees. So what does this mean? Well, in the absence of a vaccine, you would expect 500 in the vaccinees. So 400 cases were prevented in this group, and that is 400 out of 500, 80% protection. So that's essentially a demonstration of 80% protection against infection. And that would be quite good. In fact, the WHO and others are saying that a vaccine over 60% would probably be acceptable. So this second example is a little bit different. Again, 20,000 subjects, half receiving the vaccine and half controls. In this case, though, whilst the first 10,000 controls yield 500 cases as before, the vaccinees produce 400 cases. In other words, it's only 100 that were prevented, or 20% efficacy. This would be quite unsatisfactory for most people, and in fact, many companies would sort of throw their arms up in the air and give up at that point. But if you then follow on and say, well, what happened to the actual disease in these people? And you find that if you look specifically at severe COVID cases, in other words, you look very carefully at all the cases and you decide which ones are in the severe category, then you find there's 45 and 40 work from controls and only 5 from vaccinees. Your vaccine has now produced 87.5% efficacy against severe disease and probably death. And that's a useful vaccine. My point is that measuring infection only is not enough, and it's important to measure the effect on severe disease. And to do that, you have to have a trial where the people who are undertaking the trial have worked out very detailed systems for measuring and identifying severe cases. And this is quite a challenge. Now, these are the trials that I'm aware of that are underway at the moment with some of the leading candidates. The first thing to mention is the AstraZeneca Oxford vaccine, which everybody has been describing as the leading vaccine. Unfortunately, they have had a pause today. It was in the news today that due to an unexpected serious adverse event in one of the participants in this 10,000 person trial, the trial has been paused while they are investigating. So we're not sure what's going to happen to the Oxford vaccine at this point. The Moderna and the Pfizer vaccines which are both RNA vaccines, are seen as being the dominant candidates for the United States. And in fact, some of the material that's come from the Trump administration and from CDC has suggested that they were planning to introduce one or both of these vaccines within the coming months. But I want to point out one thing. Both of them are doing a trial of about 30,000 people, which is a phase 3 trial. Both of them are doing these trials in 100 sites. It's unbelievable. How can you maintain a consistent quality of clinical observations in a trial that involves 100 sites? This is a pattern that the large pharmaceutical companies have developed over the last 20 years. And in my opinion, it's led to very inferior vaccine trials. In years gone by, these trials would be done by academic groups and in a small number of sites. But this is the world that we live in now, 100 sites for each of those two. The other studies I've listed here, the Sinovac study, everyone here is familiar with. Gamaleya vaccine, this received some very poor publicity, at least in Australia initially, where President Putin apparently gave the vaccine to his daughter, and there was a story that they were going to license the vaccine without any trials. They are doing trials, and large ones. CanSino, I'm not going to speak about it. I don't know very much about this study going on in Pakistan. The Novavax trial is the one that I showed you the phase 1 data about before. So I'm not going to speak any longer than that, just to leave you with one of the most famous quotes in vaccinology. And this came from Jonas Salk, who was the inventor of the polio vaccine. He was being interviewed in 1955, and the interviewer asked him, who owns the patent, who owns the intellectual property for this vaccine? To which Jonas Salk said, there is no patent, could you patent the sun? So thank you very much, and terima kasih, and I'm looking forward to any questions or comments. Thank you.
Okay, thank you very much, Prof. Kim, for your deep thoughts and important information. So next, I want to welcome two panelists to share their comments and remarks. Both are members of the Immunization Task Force, IPS. The first is I invite Professor Sujat Biko. He is from he is Professor of Pediatric from University of Indonesia, Jakarta. Now he is the Secretary of Immunization Task Force, IPS, and member of Indonesian NITEC, ITAGI. Please, Prof. Miko, you can start your.
Yeah, thank you, Professor Sisi, and also thank you, Professor Kim Holland, Professor Rusels, and Dr. Anggraini for your sharing information. It's very nice, and I would like to share one slide that's only to give a comment and also question to the presenter. It's already.
No, not yet.
Not yet. Okay. Just look for one person can share time. Okay. Share screen.
Share screen.
Yes.
Yeah.
This one, and then okay. What happened? Share. Okay. And then yeah.
Okay. Perfect.
Thank you. Yeah. Sorry. Yeah. Well, thank you. Based on title today, that's we're talking about the new adaptation era. You already explained by all the presenters that the COVID pandemic have a huge impact on the health services and the economic and all education and also social life. But I'm just focusing today just only in disruption of the routine immunization. And we know that during the pandemic, the reduced routine immunization have a risk of outbreak of vaccine preventable diseases on the future or in the for the time being. And based on the second title, we have to talking about the future vaccine COVID. As already explained by Professor Holland, that yeah, we lack of information about the safety, about the immunogenicity, about the efficacy, and also when we have a conclusion and how many doses Indonesia will have the vaccine, because the priority is children is lower because the mortality in Indonesia below 4 years old of age is around also 1.4%. Yeah, it's although higher in the world, but it is still lower rather than the elderly. Based on the two title, I would like to uh, agree with Professor Russell that we have to talk not only a problem about the prevent during the COVID pandemic, but we also encounter how the problem after the pandemic. And as a secretary of Indonesian Pediatric Society Immunization Task Force, I'm focusing on how to prevent also in the risk of outbreak FPPD. The first I share that as already presented by the presenter, we have to strengthening to the family to do the healthy life behavior every day by masking, hand washing, distancing, bathing, disinfectant. But we also we have to remember that the parent who work out of home have a risk to infect their children or elderly in their home. So we have the disinfectant of the anything they have to bring to home, like shoes, bag, belt, and help. It is must be we have to concern about it, and also how to strengthen the family to don't go to the school, market, restaurant, crowded public area gathering, not only for children but also for the parent and the family member, and also the important of well nutrition and well activity, not only physical activity but also psychomotor, because and emotional at home, because the happiness may be strengthening the immune system, maybe explored by Professor Zakiuddin. And the other one, how to encourage the family to complete the child immunization, because most of the parents they don't they're afraid about the infected on COVID. They so the immunization coverage in Indonesia decreased below the 50%. This is should be done by the family, and what should be done by the health services. The first is already the strength explored by Professor Professor Fiona for results. The health services should be earlier make a diagnosis of COVID. Although it is difficult sometimes because the symptom is, but the earlier diagnosis, it is safety for not for children itself, but also saving for the elderly the family member in the same home. And the second, that is the important one, the PPD's immunization should be completed by parents, especially children or babies below 18 months old. As we know that baby were born since March until right now, I'm afraid that most of them, they don't have any complete immunization. So we can imagine it every month about 400,000 baby born every month. How many baby born baby don't have any complete immunization? And the second group is the member of 2 and 6 years old. The national program, we don't have any special this for this, but actually we can use as the group for the check how about the immunization below the 1 year. This is the opportunity. And the school age is also important, as we know that in the school age, some of the antibody should be decreased. So all of the age group should be prevented for outbreak. And some of the experts say that, oh, we don't have any outbreak during pandemic. Please don't remember that. Please remember still that all children still stay at home, there may be the contagious, the infectious spreading is lower rather than if they go to school. And some of the staff in the Ministry of Health say that the surveillance staff is mostly work for COVID. There may be some outbreak of PPD not recorded by this staff. And how after pandemic, if there are so many children in complete vaccination, they go to school in crowded area, they have risk of outbreak of PPDs. So in my opinion, the PPD immunization completed should be one of the focusing action in during pandemic and especially after pandemic. How about the SARS-CoV vaccination? This is the question already answered by Professor Kim Holland. We don't have any information about the clinical trial for children right now. We don't have any information about the safety, about the efficacy, and how about the bridging study and interim study, and how many vaccines that we have for children in our country, because the maybe the priority for the parent. That's already so. And when and how to prioritizing, and when, so it is too long. So because we don't know where is the pandemic finish, and we don't know where when is the immunization COVID SARS-CoV-2 for children. So the strategy number one and number two, it is more important. How to the government and all the professionals strengthening the family to still daily healthy life behavior. We don't talking much about the hoping of vaccine, because if we much talking about the hoping of vaccine, they neglected the daily healthy life behavior. Yeah. And the second, we as the health staff, as the health professional, should be encouraged about the giving completed PPD immunization for all age group. That is my opinion. What is your opinion, Professor Kim Holland and Professor Russell? Thank you, Prof.
Okay, thank you, Prof. Sujatmiko. And now I want to welcome Professor Zaki to deliver his comment and remarks. Professor Zakiuddin Munasir, he is a member of Professional Services Development Board, MPPK of Indonesian Medical Association, and head of the Protection and Development for member of Indonesian Pediatric Society. And he is also executive board member of the APAPARI, the Asia Pacific Association of Pediatric Allergy, Respirology, and Immunology, and editor for Asia Pacific Journal of Allergy. Please, Prof. Zaki.
Thank you, Professor Sisi, and thank also for the three speakers with a very, very nice and also very interesting presentation. As we know that the pandemic of COVID-19 is, I think it's very difficult, the most difficult epidemic, as we know that by this pandemic, and we make a greatest effort, for example, like using masks, social distancing, and also vaccination, and try to get the drug. About the vaccination, I think for make a vaccine to COVID, we are in hurry, not like as a make vaccination before, like for example in varicella epidemic or polio epidemic. I think we make in hurry, and if we optimist, we can finish or get this vaccine in 12 to 19 months, then we get a good vaccine. And also, I think we must think about the viral mutation. Also, the viral is a single strain RNA. I think the mutation may be slow. We hope like this. And about the vaccine distribution, I think the Professor Kim Holland has mentioned that the length of immunity is about 2 years. But for distribution like in Indonesia or in the world, I think need until 5 years. But before to finish in 5 years, then the immunity has end. So I think we must to anticipate about this mutation, for example, by make a vaccine from multiple angle. And if we look for the other epidemic, for example, Ebola is not too difficult because only the symptomatic patient transmit the viral. And also for HIV until 40 years, we don't have any good vaccine until now. So by this disease, I think we must to look for the very best vaccine. Before we get the good vaccine, I think we also try to get the drug, not only for cure the disease, but also for the prevention program before we get the good vaccine. The second about the school children, Professor Russell has mentioned that in Scandinavia, after reopening school in Finland, did not increase the case, so it is relatively safe. But I think the condition is different within Asia or especially in Indonesia. The transmission from children to children is, I think, rare, not easy like from the adult. But here in Indonesia, in school, the children will stay in school also, accompanied by nanny, by parent, also a lot of adult person around in school, like the street food seller. So I think the condition is different. Until now, we still close the school, and I think the school is from home. Yeah. Yeah. So besides the vaccine, so we need for information about the drug for the COVID, not only for the cure and also the prevention. Thank you.
Thank you, Prof. Zakiarin, for your great remarks. Yeah. And now we come to the session of question and answer session. We will start with the question from the chat box. Yeah. I will read the question. The first question from Professor Agus Syahrul Rahman. He is a microbiologist, a virologist from University of Indonesia. So he asked why that, maybe it's for, he said it is for Prof. Fiona. Why does cytokine storm and coagulation disorders more frequently observed in old cases as compared to children? I think adult, yeah, and to children. On other hand, viral load in children is higher than old cases than in the adult. The first question. The second, since cytokine storm and coagulation disorder pathophysiology has not yet fully understood, is it possible that vaccinated children is more prone to cytokine storm and coagulation disorder when they are naturally challenged by white virus later on? It's clear for you, Prof. Fiona?
Thank you, Susie. Can you just repeat the first one? I didn't quite catch the beginning about the viral load, I think. But
okay, yeah. Why does cytokine storm and coagulation disorders more frequently observed in adults as compared to children?
Yeah, sorry, just the first one. The first question. Sorry, I missed.
This is the first question. Yeah.
Oh,
On the other hand.
Oh, sorry, I thought there was something about the viral load in adults versus children. Was
yeah.
that?
Yes, the viral load in adults versus children. On the other hand, viral load in children is higher than in adults. About the cytokine storm and coagulation disorder.
Yeah.
Why more frequent in adults?
Yeah. I mean, maybe I can talk to a couple of those. So the viral load is very interesting, and I don't think we fully understand all of this yet. So in adults, a high viral load has been associated with the worst outcome. So there's a study that came out a couple of weeks ago that high viral load in adults is, associated with mortality. In children, we know that they do have a high viral load, being asymptomatic and non-symptomatic, but why they don't progress to have, disease is a mystery. I mean, there's a number of reasons and hypotheses for that, related to immune responses, related to the fact that, the difference in coagulation, for example, and that's sort of the reason why, older people with unhealthy blood vessels, whether they've got diabetes or, things that affect their blood vessels, are more likely to develop blood clots and vasculitis and lead to death, and that's less likely in children who have, in general, healthier blood vessels. The cytokine storm question, so that's one of the issues with, the potential reactions or the safety events that may occur potentially after vaccination, and things that are being monitored very closely in the phase 3 trials to have a look at, to see whether things like this might happen in terms of having an adverse event. And Kim, I don't know if you want to talk more about that in terms of, exacerbating these events.
Yeah, thanks, Fiona. Yeah,
Yes.
Professor, can I make a couple of comments, please?
Yeah, please.
Sure.
Of course. Sure.
Yeah, firstly, I think the question is a very thoughtful and important one, actually. And as Fiona said, there have been a number of hypotheses as to why children should be somewhat immune, somehow excluded from this disease. And the most popular one was the prevalence of ACE2 receptors. And the ACE2 receptors on the respiratory tract and elsewhere in the body are very much age dependent. So these receptors are not found in large numbers in children. And this was, of course, the early explanation. But Fiona's mentioned the changes in thrombotic tendency. And indeed, the adults who've developed very severe illness have pathology in the lungs, which is really riddled with thrombotic abnormalities. And this seems to be the most terrible thing. But the questioner is right to highlight the cytokine storm, the IL-6 response, and then the other things that seem to follow that. And I think there's a lot of work going on now trying to understand how children are somehow protected. Now, the one group of children who may not be protected are the ones that Fiona mentioned in her talk, which is quite a rare group that have this multi-system inflammatory syndrome. We call it PIMS-TS, but the Americans call it something else. But basically, it's something like Kawasaki disease. But that's a small group. So, and I think the essence of the question, which is the most interesting and somehow disturbing part of the question, is to say, look, most children get nothing from this virus. Most children get virtually no illness at all, or if anything, just something very, very mild. So if you're giving a vaccine, you may change that immune response. And is it possible that you may increase the risk of children getting severe outcomes? And that is theoretically and perhaps realistically, that is a possibility. And I think it's one of the reasons why there has been rather little interest in pursuing this vaccine for children at this stage. I think the only group which has a plan, as far as I understand it, to do a phase 3 trial in children is the Oxford AstraZeneca group, and I don't know what the timeline is for that. So I'm worried about that. I don't know how we would rule out such an event, and yeah, I'm sympathetic with the questioner. Thank you.
Okay, thank you very much, Prof. Kim. From
Prof. Sisi?
Yeah, please.
Yeah.
Prof. Saki, okay.
Yes. This is saying because in children also the comorbid is less than in adults, and beside the immune response also uh, not so heavy like in adults. So the cytokine storm is not too increase.
And that's part of it, but the reality is that there are adults, and I'm sure you've come across these in your own clinical practice. There are healthy adults, not necessarily old and full of comorbidities, that do poorly with this virus. So even healthy young people in their 20s and 30s, they may not die, but they have severe illness and may be left with sequelae. So the morbidity is not only explained by comorbidities.
Okay, thank you very much.
Prof. Sisi?
Yeah. Yes,
sorry,
yes.
Prof, if I have some maybe discuss about the hypothesis or why children less severe compare with adults. How about the trained immunity, Professor Mulholland? In Indonesia, so many children infected by COVID-19 and died caused by COVID-19 is failed trained immunity or a lack of immunization coverage also increase the possibility of COVID-19 infection in children in Indonesia compared with the full coverage immunized children in Australia. And how about smoking? Passive smokers, so it might be upregulates ACE2 receptor, and overcrowded, and maybe the sanitation or wash problem in Indonesia, instead, and also comorbid and nutritional status. But one more, the immunosenescence in adult, is it also possible to make adults have a severe clinical manifestation? Thank you. And my second question, Prof, you said about the...
Can we postpone the second question because many in the chat. Prof. Okay, sorry. Okay. So maybe Prof Kim can...
Just briefly, you mentioned a number of different and quite important factors, and some of them were counteracting factors. You started by mentioning trained immunity, and indeed the notion of enhanced innate immunity may tie in with issues that we relate to things like the so-called hygiene hypothesis. And Fiona mentioned in her talk the rather dramatic findings from Kenya. And I can tell you that I've been very much involved in what's going on in India. And despite the large number of cases in India, the mortality is much lower on a population basis compared to the number of people infected than any European countries. But interestingly, it seems like it's to do with socioeconomic status and class. And in a meeting we had last weekend, a number of the Indian doctors pointed out that the mortality amongst Indian medical practitioners has been very high, as it's been in Indonesia, and that the people who seem to be more protected, if that's the case, seem to be those people who are living in more difficult circumstances. So that ties in with the idea that that exposure to other pathogens and exposure potentially to pollution and other things may have an impact on trained immunity, such that those individuals become less susceptible to very severe disease. Very interesting area, but not easy to explain. And I have no explanation for the large number of deaths in Indonesian children, except that in the discussions that we've had, and Prof. Sissi may be better to comment on this, my understanding has been that the deaths that have been confirmed as COVID deaths have been in children with serious underlying conditions. Prof. Sissi, would you concur with that?
Thank you. In our discussion last week, that we discussed about why the number of death in Indonesia is very high, but when we see maybe due to malnutrition or maybe to poverty, we don't know. I don't think we have the answer now. Can we
comment?
Yes, please. Oh, yeah, Fiona, please.
So just on that, I just think it just really highlights the importance of, the thing that I was mentioning in my talk, and just sort of understanding the epidemiology, because there are so many mysteries. And as Kim has sort of said, in children in low-income country or people in low-income countries, it seems like the more marginalized, poorer people might be protected somewhat, but in high-income countries, it's kind of the opposite. And so it just really highlights the importance of really understanding the local epidemiology, I think. Yeah.
Thank you, Fiona. Now maybe I can read the second question to Professor Russell. As long as I know, none of the corona vaccine presently doing a trial in children, even in young children less than 18 years. Will one of the vaccine product available soon as the adult coronavirus vaccine? From Willy Gunawan, Lampung, from Lampung. Please, Fiona, maybe. So, will we have one vaccine for children as early as for adults?
Yes, I think Kim might have alluded to this a little bit earlier, that there's very few manufacturers that are doing trials in children as yet because of the potential of safety concerns, because the risk of severe infection and disease is quite low in children. And there is this potential to have this safety side effects in children produced by the vaccine, that there's not many companies that are currently enrolling children in the vaccine trials, but maybe that will come later. But at the moment, I think children are probably towards the bottom of the list. Yeah.
Thank you. Prof. Kim, maybe you can add your...
No, I'm in agreement with what Fiona said.
Okay. So there's another question from Vladimir Fiardo from Surabaya to Prof. Kim. Is it necessary COVID vaccine for young children or neonatal? As I know, it's only for children more than 12 years old. And are there some conditions that put children are not eligible to get the vaccine?
Yeah, I think it's similar to the last question, and I think the answer is that as children are the least affected by the disease, then it's a lower priority, and those who are most affected by the disease are adults. Of course, my age group is the most affected, but in fact, there is a lot of serious disease occurring in younger people. In India, for example, in Delhi, 50% of the deaths are in people under the age of 60. And those people are, at least in my way of thinking, those are young people. So that that's half of all the deaths in Delhi are in that age group. So you see rather few deaths in India in people under the age of 12. There are teenagers, yes, but not under 12. Really.
Okay, thank you, Prof. Kim. So this question is for Professor Fiona and Dr. Anggraini. I heard in Israel, I forgot the country to be honest, to collect sample for diagnostic from nasopharynx, they use gargle method. Do you think it is suitable for children as it is less harmful than doing swab? Please, Prof. Fiona, and then Dr. Anggraini.
Yes, in terms of sampling, the nasopharynx is a bit challenging, I think, to for some people, because it has to be very deep, into the nasopharynx. It's been such a long way. There's a lot more testing. I don't know about the gargling method, but there certainly is people looking at saliva and spit, essentially, sort of looking at spit and looking at immunological responses. And there's been a lot published recently on that, but still the standard test is a nasopharyngeal swab, but saliva is coming there, and there's a lot, and Kim might want to comment more on that, but certainly people are looking at that because it is very traumatic, and saliva you can take from home, self-sample, be much more convenient to be able to do that.
Okay, thank you. Maybe Dr. Anggraini first, and then Prof. Kim, maybe will
Thank you,
add.
Prof. So saliva right now is the previous one or study for take sample for COVID-19. And if the study and in this study taken part in US and also in Israel. So if there's success, we have a diagnostic test, very simple, and it cost maybe just $5 to $10. No CTM, no need swab or a special tool to take the specimen. Thank you, Prof.
So, okay, thank you. Now the question is for Prof. Sujat and Prof. Zaki. So what is your recommendation for opening school? Maybe Prof. Prof. Kim, do you want to add about the gargle method?
Well, I'll say it's an interesting idea. Saliva is, as Fiona said, I think saliva is probably not quite as good as nasopharyngeal or nasal swabbing, but probably better for use in children. As far as the rapid tests are concerned, there are a number of different rapid test approaches. The most usual rapid diagnostic test that's on the market is actually an antibody test. And so logically, that's not going to come positive in the early stages of the illness. So that's a bit of a problem with that as a test. There are a number of antigen tests, rapid tests that have been produced, which are not, the evaluation that WHO did of those tests found that there was, hang on, Fiona's just written, she's going to contradict what I'm about to say, but was that none of them had really proved to be very effective. And I don't think any of them are fully approved. There is a system called the LAMP system, which is a kind of a isothermal PCR system that the scientists will know about, which has been used in the past for other antigens. And there are several groups now that have developed LAMP systems, particularly in India, and also there's a group in Australia doing this, which may provide a kind of low-cost PCR system that can be applied without the usual machinery and can be used in small hospitals and could be very useful in Indonesia for district hospitals or for the more remote areas. It may offer a good diagnostic test. So that's a few comments about the diagnostics. Sorry, that's all.
Okay, thank you, very clear. And thank you, Fiona, for sending us the link for the saliva examination. To our panelists.
Last question, maybe?
Also, the last panelist is, there is a question. So what your recommendation for opening school in this pandemic in Asian country, especially Indonesia itself? It is better still close or soon open with some condition, please, Professor.
I extend this question. May I extend because it related this question? Professor results show the data that the transmission between child in some countries is not as high as the UK and America and I forget it, Israel. In my opinion, the concerning about to school it's not for their risk, the safety for the children, but also safety for the elderly who live in the school in his home, and also the younger, because in Indonesia, below 4 years old, the mortality is 1.4%. It is higher rather than other countries most of countries show below 1%. So what is your opinion regarding your data you have, Professor Rosals? Yeah,
Yeah.
to this extent, because this is the school age, it's not so severe. It is, but the risk to distribute to infected the elderly and the younger. Thank you, Professor Russell. What is your opinion?
Yeah, no, great. Thank you for bringing that up. That's a great thing to talk on. So really the, you know, most of the transmission that we're seeing is in the household, as you've rightly said. So if the elderly are living inside the house and the kids are bringing it home, then that's an issue. Obviously, you know, to protect the elderly, and the school closure is somewhat complex, but you know, when there's low transmission or zero transmission, then opening up, you know, would be a safe thing to do, and with all the mitigation measures, masks and hand washing and ventilation, all those sorts of things, of course, not just as normal. And so in Indonesia, you know, as I understand, things are still quite high in terms of community transmission. So it's certainly something I you know, wouldn't be recommending when there's a lot of community transmission, because we know what happens in the community then happens in the school. And so the parents or whoever gives it to the kids takes it to the school, and then the kids bring it home and takes it to the family and gives it to the elderly people living at home. So it's all very related, obviously, to how much community transmission is going on. So you can't sort of separate schools from what's going on in the community. So it really, you know, what we're looking at in Victoria, so at the moment we're looking at all the Victorian data, because, you know, as you know, Australia's essentially more or less free of COVID, more or less, except for in Victoria. So we're still in lockdown, all the schools are closed. And what we have found, and we're analysing all the school data in our state of Victoria, and there has been quite a lot of outbreaks. I can't probably speak too much on it because we haven't released the report yet, but really just to say that in our setting anyway, we have not seen that transmission to the elderly, but we live very differently. You know, a lot of our grandparents, my parents don't live with me, you know, for example. And so we live very differently. And that's why it's so important to understand in your context, you know, in the way that people mingle and live, you know, what the epidemiology and the risk is. And so that's why I'd, you know, really strongly encourage these epidemiological studies to really understand in your circumstances, you know, making school safe, you know, in your situation. So yeah, and I also just want to make some other point. Your slide that you showed is absolutely, you know, spot on, I think, in terms of the number one thing. We know what works. We know what works to prevent COVID. We know wearing a mask, we know washing hands, we know, you know, physical distancing, having good ventilation, all of those things, we know that works. I mean, we know that already, and that is up to us, every one of us as individuals. What we don't know yet works is vaccines. So the vaccines is kind of some fantasy, some sort of wishful thinking later on. But even the first line of vaccines probably won't be 100% effective, and not everyone will be vaccinated. So we have to keep going on with all these things that work, and have to really understand, because we can't have children not at school forever either. So it's really important to sort of really, you know, understand this a whole lot better. Sorry, I probably went on a little bit too long, but I hope I answered the question.
It's okay. Oh, it's okay. Thank you very much, Fiona. So maybe we will go to Prof. Zaki. Prof. Zaki, can you answer or give your opinion? Prof. Zaki is no more here. Okay. So we will move to another question. So this is from Agung Gautama, and it's similar with the one from Willy Gunawan. So Prof. Kim, if there are many vaccine produced and they finish, which one is the best according to you? Which one we have to choose? Which vaccine? With different platform.
That's quite let me say that's an impossible question to answer. But I would point out that all of the vaccines are different ways of delivering what is essentially the same protein, that is the spike protein. So it's my view that I think that they'll probably all be effective to some extent. The duration of protection may vary. The ability to produce the vaccine may vary, and also the effectiveness in the elderly may vary. It's very unclear. I wouldn't bet on anything. People were saying the Oxford was the most, the best looking one, but I think they were the best at promoting the AstraZeneca vaccine. The Russian vaccine is a similar idea to the Oxford vaccine, but they're using two different adenodes. It's very interesting. It might turn out to be better. We're doing trials because the trials are designed to be able to show us which ones are better than others. But unfortunately, the WHO attempt, I think, to do multiple vaccines in the same trial seems to have stopped. And that's a pity, because it's really only by running the vaccines head to head that you can actually really judge which ones are better than others or which ones are equivalent to others. It's possible that in India that may happen with some of the Indian vaccines. That's still under development. So the answer is, I think that probably they will all be effective to some extent. And I would encourage everybody here to look very carefully at the results as they come out. Don't just look at the bottom line, what they're claiming. Have a look at what they've actually done, and think it through and figure out which one you think is better, because the way that vaccine trials are presented is not always equivalent, and you have to be very careful as you read the papers, and you should read the papers carefully and try to understand how the trial was done. And my last comment, which is for the statisticians here, and that is that if the vaccine trial is done well, you should not need a statistician. It should be very easy to analyze, but it's not always the case.
Okay, thank you.
Prof, may I ask Prof. Moholan? Prof, because the vaccination or a vaccine, we will wait maybe 1 year later. And in Indonesia, the positivity rate is very high, more than 10%, and it still increased and also died. How about your opinion about the herd immunity of COVID-19?
Well, that's a question that requires about a half-hour answer. According to the original modelers, and these are, I'm thinking back to the models that were presented by Anderson and colleagues from Oxford in January. The estimate was that herd immunity could be achieved given that the R0, or the number of secondary cases that each individual case would generate, is about 2.6. Then they estimate that herd immunity would be achieved once 50 to 60% of people were immune in Britain. And remember, the R0 figure, for people who are interested in this, is not a feature of the vaccine. It's a feature of the vaccine and the community. And the R0 will be very different in a more crowded and difficult environment. Now, in India, in Mumbai, which was the worst affected city initially, there is a district called Dharavi. It's a slum district, and it's 2 kilometers squared, and it has a population of 1 million people, close to 1 million people. So it's a very crowded area in a very poor part of India. Now, this area has about 60% of people are seropositive, and the virus has spontaneously stopped in that place. So you could say, oh, that's exactly what Professor Anderson from Oxford was talking about in January. Well, yes, but you can't imagine a place more unlike Britain than Dharavi. So it suggests to me what Fiona was mentioning, I think, which is that there are probably other immune factors at play here, and that in fact, there probably is a possibility for herd immunity in some settings and under some conditions. And I believe that we need to be looking fairly closely at this, because it is possible, I think, in some settings. I don't agree, which is just do nothing and wait for the virus to go away. I think that that's going to, especially in Sweden, that's not a good idea. But I think that it's something that in Indonesia, it would be very interesting for you to know in the different areas of your big cities, for example, how high the seroprevalence really is. You may find some areas like Tarapi, for example. And the Indians have done some excellent serosurveillance that's really thrown a light on the way this virus operates. So herd immunity, very interesting. I'm not relying on it myself, but I think that in some areas it's going to be useful. And so I would really encourage Indonesia to look carefully at these issues of, perhaps herd immunity is the wrong term. Paul Fine in the very large vaccines textbook prefers to refer to community immunity. And he changed the name of the chapter from herd immunity to community immunity, which he thinks is more realistic. And I think that's probably true. Thank you.
Thank you, Prof.
Thank you. And this is maybe the last question for Professor Russell. It was fascinating and shocking fact that you gave that there were low transmission among school children, especially among primary school students. But until now, Indonesian Pediatric Society is still standing on the position that schools are not allowed to open. What is your opinion?
Sorry, thank you very much for that question. It's a really important one. And it's again, it reflects the school opening is very much dependent on the incident, or what's happening in the community. So if you have a whole lot of community transmission, then the safest thing to do would be to have the schools closed for a variety of reasons, because you have to get transmission under control. But when you've got low levels of transmission, so as in that England study, it's shown that even, that it is a safe time to open up, because when that England study was done, it was when there was low levels of community transmission. So it really depends on the level of community transmission that you've got, because what's happening in the community will influence the amount of transmission that happens in the school, and that will influence how much transmission happens in the household. And so they're all related. And if you don't stop all of that when community transmission is high, then you won't get the infection under control, and the epidemic will just keep going. And so, the decision to open and close schools is based on the prevalence or incidence, whatever, the number of cases that are happening in the local community at the time. So I hope I didn't give the perception that go forth and open the school. That's sort of not what I was saying. I wasn't meant to say. It's really dependent on what's happening in your community and how much community transmission there is, and decisions are based on that. Yeah.
Okay, maybe you will add, Prof. Kim?
No, it's okay.
No? Okay.
Prof, if you don't mind, I want to add the answer or the clear reason why in Indonesia we still closed the school, because we know the reproduction number, the R0 is still high, more than 1 in Indonesia, and we have not yet low cases in COVID-19. The WHO said that minimum 50% reduced of COVID cases within 3 weeks, and the positivity rate should be less than 5%. So all of the WHO recommendation cannot achieve in Indonesia right now. So that's why we still close. We still give recommendation to close school. Thank you, Prof.
Yeah. Okay. Thank you, Dr. Anggi. There are still some questions, but because of the limitation of time, however, due to limitation of time, we apologize. that we have to end the discussion. Now we come to the end of our meeting. Maybe each of the speakers and also the panelists can give this last take-home message or the last statement. Please, Prof. Fiona, what is, maybe you want to speak something for as the last,
Closing
the
remarks.
final?
Yeah, no,
Please.
thank you very much. Thank you again, everyone, for the invitation. I would just like to reiterate just how important, your local epidemiology is. And it may be very, somewhat quite surprising from other countries or some differences. So I think that's my sort of take home message, is sort of understand your local epidemiology.
Thank you. So Dr. Anggi, please. Dr. Anggi, can you say something, this last statement?
Thank you, Prof. Sorry, I just unmute my microphone. Thank you, Prof. So the infection control in your hospital or your clinic is very important as a pediatrician, because maybe we have patients without symptoms, but we know right now that children may drive the viral maybe as much as adult or maybe higher than adult. So we have to do maybe right now telemedicine and the appointment and prepare your consultation room clearly with open air, something like that. And we hope that the infection control system will prevent us from infection. Thank you, Prof.
Okay, thank you. And now, Professor Kim Mulholland.
Well, thank you. My first comment is that the other speakers, other than myself, I think had much more important things to say when we're talking about the control of COVID-19 in the pediatric community. And the reason I say that is because all three touched on many important practical issues that really have to be laid bare. And myself, I'm extremely worried about the vaccine preventable disease issues and the coexistence of a large population of non-immune measles, potential measles susceptible children with what Dr. Tedros at WHO described as a pandemic of malnutrition, where in many of the poorer communities in the world, many more children will become malnourished and susceptible to measles. And I've personally had the uncomfortable experience of trying to manage measles epidemic in a highly malnourished community, and it's a really, really bad situation. So I'm very worried about measles. I know it's not what I was meant to talk about. I'm not really convinced that the vaccine is going to be the answer for children. I think all the other things that you've been talking about are far more important, actually. I hope that the vaccine turns out to be effective and controls the pandemic. But at the moment, I think it's an open question. Thank you.
Okay, thank you very much. And now your turn, Prof. Jatmiko.
Yeah, thank you, Prof. Sisi. The first is we don't know when is the pandemic is finished. We don't know when is the vaccine for children is available. So the parent and government should be strengthening the parent daily health behavior, not only physically, mask wearing, hand washing, distancing, and also disinfectant. Also psychosocial and emotional for children by playing, dancing, singing, drawing. Yeah, and the third, encourage the parent to ask for the complete the immunization for all the children. And the third is as the medical staff or the professional pediatrician, we have to provide call for completed the immunization for our patient, our children, our all children in Indonesia to all the vaccine preventable diseases for prevent the PPDs, prevent the measles, as already stated by Prof. Kim Kuhlman, measles, diphtheria, and polio, and maybe influenza, pneumonia. So complete it all before not waiting the pandemic finish. But right now we have to complete it all group children should be completed with immunization, routine immunization. Thank you, Prof. Sisi.
Okay, thank you. And now I invite Prof. Zaki.
Thank you, Prof. Sisi. This is my closing comment. The first about reopen the school. We can reopen the school if the new normal condition by WHO has been fulfilled, especially if transmission rate already controlled are all less than 1. The second, we must also remember about the principal condition by Center of Disease Control. More the people and along the people interaction with the student and increase the transmission of COVID-19 in children. So we can minimize this. Before we get the good vaccine and also good medicine, we still do, like Professor Sujatmiko said, that the social distancing, using a mask, embosser, and so on. Thank you very much.
Okay, thank you. Maybe the latest is from Dr. Prof. Hartono. Do you still here, Prof. Hartono, please? Or maybe not anywhere. Now we come to the end of our meeting. Hopefully, all of you participants enjoy this webinar, and thank you to all speakers, Prof. Fiona, Prof. Kim, and Dr. Anggi, and also panelists to Prof. Sujat and Prof. Zaki, and to Prof. Hartono. I think the most important is I want to thank all the participants to making this webinar successful, very fruitful. Yeah, I hope that this to meet you in another occasion. Assalamualaikum warahmatullahi wabarakatuh. I close this meeting. Bye-bye. See you next time.
Bye-bye.
Thank you, Prof. Fiona, Prof. Kim.
Thank you.
Thank you. Sami-sami. So we usually meet Prof. Kim and Prof. Fiona every Monday. So when you want to join us, please tell me about that. Okay.
Thank you.
Bye-bye.
Bye, Prof.
Thank you,
Mohalan.
Prof.
Bye, Prof. Russell.
Thank you,
Bye.
Prof. Russell.